I think this is one of the most different diagnoses in DSM, and it took me a little while to just figure out kind of where is everything and where did it come from. So this is not complete, and I'll just read you a list of what's now going to be under this trauma and stressor-related disorder. Reactive attachment disorder, disinhibited social engagement, acute stress disorder, PTSD, and that's, as you mentioned before, that's where the adjustment disorder is going to go now. So this is all, the PTSD has been pulled from the anxiety disorder category. The reactive attachment disorder has been pulled from where disorders first seen in childhood. The disinhibited social engagement disorder was a subtype of reactive attachment disorder. Now it has its own diagnosis. And the adjustment disorder was pulled from its own category in DSM. So, you know, once you realize that all of these sort of old friends are now joined in the same area, it's not as shocking because the criteria haven't changed in so many dramatic ways. But I'll just tell you a few ways in which they've changed. First, I'd like to mention the acute stress disorder, which was the kind of, you know, early, potentially prodromal aspect, form of PTSD. So for acute stress disorder and PTSD, it is no longer necessary that the person responded with horror or intense fear at the time of the event. And this is because it's been found that well-trained soldiers or EMTs may be able to manage a traumatic situation pretty well and then still develop PTSD afterwards. So that's being removed. Also, you have to be explicit about whether the trauma was experienced directly, indirectly, or vicariously, or as a witness. For adjustment disorders, I mentioned a moment ago, it used to be its own category. It was a kind of residual category that a lot of us would use when we needed to give somebody a diagnosis, but it seemed to be sub-threshold, like if somebody's anxious but not anxious enough, or depressed but they don't have major depressive disorder. So it really was very much a residual category. And now it's really supposed to be part of the spectrum of reaction to life stress. So the subtypes are going to be the same for attachment disorder, adjustment disorder. PTSD is going to change quite a bit, and I think that in some ways it explains why PTSD was pulled out of the anxiety disorders diagnosis. The feeling of the work groups is that PTSD is not just a sense of heightened reactivity to anxiety-producing events or to traumatic events, but it's also related to, it also involves a lot of emotional and experiences, changes in emotion and emotional numbing. And that is very different from anything you see in OCD disorders or in the anxiety disorders. And of course, the other thing is that the other unifying aspect of all these disorders is that they're related to external stressors or the pathogenic realms. Okay, so for PTSD, there used to be 3 clusters: re-experiencing, avoidance, and numbing, and arousal. Those were thought to be the central 3 clusters of the PTSD syndrome. And that's being broken apart just a bit. We still have re-experiencing, we still have an arousal cluster. It's changed a little. The arousal cluster is now going to include both the traditional ideas of arousal, like tachycardia, or rapid breathing, or intense startle response, but it will also include irritable and aggressive behavior, which so many of us see when we work with people with PTSD, but we don't exactly know, now it can be part of the diagnostic process to note those. Re-experiencing is pretty much the same as well. What's different is that avoidance and numbing are now being separated into 2 categories. So there are going to be 4 clusters that are central to PTSD. Avoidance is going to look pretty much the same, but the numbing is now going to be called persistent alterations in cognition and mood. And so that will include both numbing and persistent emotional states. This is being done because it appears, for one thing, it gives sort of more respect to the very broad emotional problems and affective problems seen in people with PTSD, things like anhedonia and detachment and negative view of the world. But also this seems to be predictive of more intense PTSD and a poor long-term prognosis. So in any case, you will see this fourth cluster that will include numbing and changes in cognitions and mood. The final change for PTSD is that the diagnostic threshold is going to be lowered for children and adolescents, and also there's going to be some separate criteria for kids 6 and younger. I think this is another very important change, and that's taking out the reactive attachment disorder from where it used to be and now bringing it under stressors and dividing it into 2 subcategories. So you have your reactive attachment disorder, which involves emotional withdrawal, hypervigilance, ambivalence, children who, because of pathogenic upbringing, no longer, they don't seek out adults in times of distress. They seem, it's an internalizing disorder. It's a disorder of a child who has experienced lengthy either changes, either lengthy abandonment or abuse, and so they're scared and they don't connect. That was pulled away from this new diagnosis of disinhibited social engagement, which used to be a subtype of reactive attachment disorder. And this is a group of kids who respond to pathogenic experiences by a lack of selectivity in attachment figures and indiscriminate sociability. They may also be defiant. They may have ADHD. This may be a more enduring pattern. So we're now, and the reason they were separated is because the prognosis appears to be different. It appears that a child with reactive attachment disorder, if they're shifted into an environment where there is much more better support, more consistent parenting, greater safety, greater consistency, they often have a fairly good outcome. The disinhibited social engagement group doesn't have as good an outcome. They may have many difficulties in long-term relationships. They have problems in school. They may have a few secure attachments, but there also may be tremendous behavioral problems. So I think this is a good separation, and it'll be interesting to see what the longitudinal studies show about the outcome for this 2 group. Now, there are a lot of people who were interested in these areas who feel that the DSM just didn't go far enough, and that there just should have, that we now know enough about reactive attachment disorders and models of attachment that we could have said more about the adult version of some of these disorders, but you're not going to see those in the DSM.